Assalamu alaikum, everybody. Good morning. So we continue with the rest. Today is the final lecture for me with you of this block. I received a request regarding a blueprint. I've never done one, so I will try to do one for you this time around. Even though I think the material is not really that hard, if you ask me. If you agree with that, probably the sum of the material, the amount, of the material that is between MSI and derm is going to be a lot, but that will prepare you for other blocks, including the GI and including the umbilical of semester 2. So starting with bone tumors. We're going to be talking about bone tumors, and there's also a couple of soft tissue tumors that we're going to be talking about. So bone tumors in general, like all other organs, the benign will be far more common than the malignant. Okay? And when it comes to malignant, which one do you think is going to be more common, primary or secondary? Secondary is going to be far more common. So the bone is one of the sites in the body that receive a lot of metastasis actually from all organs. So most common malignancy of the bone, then the site that gives it, the most is the breast. The breast cancer is the most common actually lesion giving rise to bone metastasis. Most of the metastases that emanate from breast cancer are osteolytic in nature. So they are going to resorb the bone. There are other tumors that does it as well. Now the nature of the metastasis, we studied that in the POD if you guys recall. There is the osteoblastic and the osteolytic. The start of the osteoblastic, probably the most common, the overwhelming a number of cases, emanates from the prostate cancer. Okay? But breast cancer could also give rise to osteoblastic metastasis. Now with osteoblastic metastasis, what do you expect the alkaline phosphatase to be?
Increased.
They'll be through the roof, right? And is it gonna weaken? Is it gonna weaken or strengthen the bone, osteoblastic? It's gonna weaken the bone, right? Because actually these are newly laid out bones that did not have the time to actually be remodeled to give it the strength. So even though there's a lot of it, but too much of anything means nothing. So whereas the osteolytic, that itself actually, if you recall also from the POD, what are the mechanisms of the osteolytic metastasis? Give me two mechanisms of osteolytic metastasis.
Call it integrating enzyme.
How about that? But what are they? You have to give me what is happening.
MMP, parathyroid
Hydro-
Right. So PTH like peptide, right? Parathyroid hormone that will go and actually, activate, if you will, the osteoclast. And what else? There's also IL-1 like peptide, right? IL-1 like peptide or IL-1 like cytokine, if you will, that is also going to go and activate the osteoclast, making it resorb the bone, weakening the bone. So either way, whether osteoblastic or osteolytic, both of them actually predispose to pathological fracture. This is a picture of, this is an X-ray of an osteolytic metastasis. Okay, you can see that it is everywhere. All of those regions where you see that it's becoming way too radiolucent, are actually osteolytic lesions. All of them. All right. Here is a picture showing you osteoblastic metastasis. All those lesions are osteoblastic metastasis. What is that going to result into? Let's see, you guys have just finished heme. What is that going to result into? Anemia. What kind of anemia?
A+.
No, not A+. How about this? Hey, let me ask you this. We're not going to turn it into a heme lecture. Is aplastic anemia the proper name for aplastic anemia?
No.
No, because it is what?
It's everything.
It is everything, right? Trilineal hypoplasia, correct? All right, so actually, the best name for it is going to be red cell aplasia, really, if you think about it, right? This is the actual name of aplastic anemia. Where do you see red cell aplasia?
Myelofibrosis.
Say it again.
In myelofibrosis.
Myelofibrosis, you will see similar to what you see here.
Osteoporosis.
Sorry?
Osteoporosis.
Osteoporosis. Also similar to what you're going to be seeing here. Parvo.
Plastic crisis.
Parvo B19 viral infection, that's going to give you the actual aplastic anemia, because that's actually the aplastic, the red cell aplasia, right? This is where you see it. All right, but whereas actually, whereas the aplastic is a misnomer, and they say, that misnomers are hard to die, so the name stuck. But the kind of anemia you're going to be seeing here is myeloptysic anemia. You guys recall that? Myeloptysic, I also gave it to you actually in POD. So this is when the bone marrow has been occupied by a lesion, and as a result of that, all the normal bone marrow elements will be kicked out of the bone marrow house, right? Where will they go?
Liver and spleen.
What do you call this mechanism? They will go to the liver and the spleen and the skin.
Extramedullary.
Right, excellent. Extramedullary hematopoiesis, but to get there, what do you call it? They call it homing back to where they came from. And the reason for this is that they have what we call homing receptors that is going to attach them, to take them back to where they came from in the fetal life, okay? So if you examine the skin of someone who is actually, who has myeloptysic anemia, what will you see? Bumps.
PTK.
What are those bumps? No, other than the PTK. What are those bumps? Those are actually the extramedullary hematopoiesis. This is the islets of hematopoiesis that is happening in the skin. Of course, you're going to see it in other organs, as you said, in the liver and in the spleen. What do you call, the picture in the blood that is going to result from this right here? Sorry? Leukoerythroblastic reaction. Excellent. So leukoerythroblastic reaction. Excellent. So what is that actually? Explain to me.
Red cells, white.
What do you call that? Left shift, right? Left shift. And why do you call it left shift? Because you're going, all the way to the opposite side of maturation, right? You're going towards, the earlier, precursors of both the white blood cells and the RBCs. All right, so here's another actually example of osteoblastic metastasis. This is what is going to result in what you call osteosclerosis, or a whiteout. There's so much of this bone that has been laid down here that it's gonna look completely white. This is what you see. If you recall, where else did we see it?
Osteoporosis.
We saw it also when you are. Say it again.
Osteoporosis.
Osteoarthritis. You recall, as a result of the irritation that's happening to the osteoblast. After the cartilage is gone, what will happen to those osteoblasts that got irritated? They will start to produce more bone, right? And as a result of that, you will see that there is subchondral osteosclerosis, or this is the bone beneath the cartilage that is going to become sclerosed, similar to what you see here. But in this case, actually, this bone has been laid out so fast, it is really weak. So too much of anything is not really something to help. In this case, this actually itself may result in pathological fracture. All right, so clinical presentation. Usually benign tumors, will mind their own business. They are going to be, of small size. That's a very important thing. And the reason for this is that the mutational drive behind them is really simple. So as a result of that, when it comes to the number of division, they have what you call a threshold. They cannot really exceed that. Whereas a malignant tumor, the most benign or the most docile, if you will, malignant tumor will be far more aggressive than any benign tumor. At least this is a general rule. Does that mean that you don't see aggressive benign tumors? No, you do actually. There are many examples of aggressive benign tumors, such as, for example, the osteoclastoma, also known as the giant cell bone tumor. Those are divided, actually, if you read a book, that those are divided between into 3/3. There is one third of those 3/3 is going to be biologically malignant or biologically aggressive. All right, so, and in the past, actually, we used to do, when it comes to treatment, it used to be that actually benign tumors were treated in a very benign way, meaning, as little resection as possible. And aggressive tumors or malignant tumors used to be treated very aggressively. Now we know that this is not really the case, and that you have to treat each tumor according to its behavior. Because in old times, all malignant tumors diagnosis used to end up in amputation. And now we know that this is not really needed in some cases, where you see a histologically malignant tumor, but the tumor is actually minding its own business. It did not really go anywhere. And as a result of that, you need to treat those tumors, conservatively. Especially that nowadays you have what is known as adjuvant chemotherapy. Have you guys heard about that before? So this adjuvant chemotherapy in some cases are given before and after treatment. It's given before treatment so that it will shrink actually the tumor mass. It's going to even make it very likely that the surgeon may intervene and have a complete resection without actually resorting to amputation. And also, it's going to help in the post resection, period. Another reason for the adjuvant chemotherapy. Why do they give adjuvant chemotherapy? Have you guys read anything about this so far?
To make sure that they remove the entire tumor.
That's what I just said, but in reality, actually, there's a very good reason, another very good reason why you need to do that. Because the presumption is that the tumor mass has already, sent some emissaries in the blood in the form of, malignant cells that have escaped into the circulation. Now you are actually the treating clinician, and you're focusing all your attention on what? You're focusing all your attention on the tumor mass itself, forgetting actually that there are tumor cells that are now going with the flow. And those tumor cells are what's going to give rise to recurrences, okay? So the adjuvant chemotherapy comes in and actually take care of those before the treatment even happens. That's when the patient is still actually somehow, is still functioning intact, and he could bear actually this type of treatment. And then following chemotherapy, the resection, if resection is needed, to make sure that there are no residual tumors that are left in the site of the resection. All right, so this is just, a little bit of, when it comes to you guys are are in the, what you call diagnosis here. So for you to reach a diagnosis, you may use, some of the parameters that are listed here. Age of the patient, for example. If they tell you an abdominal soft tissue tumor, more likely it's going to be a neuroblastoma. How do I know? Because you play the game of odds. Okay? So neuroblastoma is one of the most common tumors, that you see in the very early, stage of life. If they tell you that there is a patient who's coming in who is, let's say, 15 years of age and who's coming in with a large bone mass, you don't call that chondrosarcoma, because chondrosarcoma is for late actually age. Again, why you're playing the game of odds. This is why actually the most commons and the least commons are very important, because that is going to help you a lot in reaching a differential diagnosis, of the lesion at hand. So in the case of the 15-year-old with a large bone mass that is emanating in the area around the knee, that's going to be most likely going to be an osteosarcoma. Okay, because it is, the right age for it, and it is the right location for it. So the age of the patient is something that you need to keep in mind. The sex of the patient is important. You will see that the majority of tumors happen in males. The majority of bone tumors happen in males, with the exception of the giant bone, tumor, giant cell bone tumor, the osteoblastoma. That is more common to happen actually in females, middle-aged females. The bone involved is also important. If they tell you that it is a femoral lesion arising in the area of the bone, arising in the area of the knee, this is more likely to be an osteosarcoma than anything else. If they tell you that this is actually a tumor that is arising in the area around, around any joint actually, a small tumor arising, around any joint, and has, for example, a comma shape, this is going to be an osteochondroma, more or less. Now, a specific area within the bone, we just talked about this, the epiphysis. There are tumors that favor the epiphysis region in the bone. Those tumors are going to be, for example, the osteoclastoma, the giant cell bone tumor that I just mentioned to you. The metaphysis and the diaphysis, and especially the metadiaphyseal region, is the area that is favored, to give rise to the osteosarcoma. For example, the diaphyseal region, especially the medullary canal of the diaphyseal region, is the site most likely to give rise to Ewing, tumor. So that's going to also help you as a clue to add to your differential diagnosis. Radiographic appearance, it is really suggestive. It's not really cut in stone. For example, if they tell you soup bubble appearance, this is something that you're going to be finding in the osteoclastoma, the giant cell bone tumor. If they tell you, for example, there are what you call onion skinning, where you see that there are several layers of bone that is being laid on top of each other, this is what you're going to be seeing in osteosarcoma. This is something that you could be seeing also in chondrosarcoma. This is something that you're going to be seeing in sarcoma. And the reason behind it, there is a pathology mechanism behind it, is that as the tumor grows, it's going to irritate the osteoblasts on the surface. And those osteoblasts are going to be laying a reactive bone in that site, what you call a reactive bone line. And then as it expands further, it's going to be doing the same. So you will see that there are several layers of those new bone formations giving rise to the onion skinning. There are actually there is suggestive, again, not really set in stone. There are other tumors that may give rise to a new bone that is going to lift the periosteum. Example of that, the osteosarcoma is a good example of that, but there are other tumors that does the same. All right, so but what is going to nail it for you, hopefully, is going to be the actually microscopic features. At least this is what pathologists, pride themselves about, that we are, the gold standard, so to speak. But there are a lot, unfortunately, even with microscopic, even after you get to the tissue, there are cases that are left, untreated. Not only this, actually, we know now, actually, that the name that you are, giving to the tumor may not really have any kind of clinical indications. Because we have seen, as I mentioned to you, that there are actually tumors that are histologically malignant, but they act actually and they behave as a low-grade tumor, so they don't really metastasize. And as a result of that, many fields in pathology started to look at those discrepancies, and from it emanates the molecular pathology that happens, molecular medicine, molecular pathology that happens to look at those differences and to look for a specific kind of genetic aberrations in those tumors that may be responsible for this kind of discrepancies. Of course, this happens also as a result of the advancements that happen in bioinformatics, because now we have actually tools in bioinformatics that we never really had before. And there are actually new tools in molecular medicine, molecular pathology, that use actually those tools in molecular medicine, such as molecular cytogenetics, if you guys ever heard about it, and also genome-wide methylation studies, that are actually when used with bioinformatics tool, the amount of information that will give you, no biopsy, no glass slide will ever give you, because it will give you everything about the patient. And we have seen that this is actually the case in a lot of tumors in the pediatric population. Unfortunately, so far, it is limited to the CNS, but we have seen expansion actually of the information that could be gotten from those tools, those newer tools in molecular pathology, plus the tools of actually bioinformatics. That we are getting a lot more information that we never really had access before. Okay? So imagine this. This is something that you're going to be dealing with as you actually graduate from medicine, inshallah, and move on. You will, instead of actually taking doing all the workup of the patient, reaching the stage where you have actually a piece of tissue that is going to be put on a slide and stained, and then you will do other immunohistochemical analysis on it, or if you're lucky and there is molecular tests that may actually, confirm your diagnosis, you, instead of that, you're going to be taking a piece of tissue, a sample, if you will, as a first step in management of the patient, putting it in a machine the size of, the old computers, which is like a small box. And the amount of information that this machine will give you is going to beat anything else, So you will see that a lot of specialties in medicine are going to be actually sidelined. And the only thing that will stay, believe it or not, is going to be you, the doctor, the clinical doctor with the patient. So this is actually an advice for you. Focus on medicine, focus on, believe it or not, family medicine, because there is no substitutes for those. But surgery, you guys have heard about robotic surgeries, right? And as time goes by, the robotic surgery is going to expand, and the scope, with which they, operate in is going to be also expanding. So, small advice, even pathology, believe it or not, is going to be amalgamated. It's going to be combined with radiology. Have you guys ever heard that before? So pathology and radiology, at least, this is the plan. Probably other specialties will be on board very soon. They are going to be called bioradiology or molecular biology field. One specialty that combines the two aspects of the two specialties in one. All right, so we did talk about this. We did talk about this as well. Okay. Talked about the location within the bone. We already talked about this. All right. Now, some of the risk factors for bone sarcoma, some familial syndrome. The Lee-Fromini syndrome, for example, is an example of a familial syndrome that is associated with bone tumors. What's Lee-Fromini? What is the mutation of Lee-Fromini? P53. So the guardian of the genome. So how many, do you expect only bone tumors to happen in those patients?
No.
Everything, right?
Yep.
And this is a very favorite exam on the USMLE. And they do, for example, they will tell you either that the patient have, so many tumors, over the course of his life, or, the other way that they will present to you, they will tell you that this is a patient whose father have this, whose mother have this, whose siblings have that, and this guy is coming in with bone tumor. What is the mutation? And in this case, it's going to be a P53. And also the retinoblastoma gene. Retinoblastoma, also what you call the guardian of the cell cycle, if you guys recall that from POG, is going to be associated with bone tumors and with breast cancer and also with colon cancer. Radiation therapy is a very well known occupational and environmental hazard that give rise. Ionizing radiation is the number one environmental risk factor of a lot of tumors, including sarcomas. In the past, it used to be that thymomas, which used to come in, the patient who's coming in with thymoma used to be treated with a head and neck radiation. And they found out that 10 and 20 years down the road, this same patient is going to come back with actually an osteosarcoma. All right, so we did talk about treatment. So the whole thing actually now, let's say, you're talking about 2000, the year 2000 or before. The likelihood of someone actually not losing his limb, the limb salvation, treatment used to be around 10 to 15%. Now it's about 50 to 60% as a result of the advent of, the chemotherapy that I told you about, or the, adjuvant. When they said adjuvant treatment, it could be both actually, chemo and radiation, or a combination of the two. All right, now, you will see that, some of the rules that apply everywhere else applies here. So if the tumor is a high-grade sarcoma, very likely it's going to respond to treatment. The reason for this is that we have actually treatments that go after, rapidly dividing cells. But you will see on the other hand that low-grade tumors are harder to actually treat in a medical way. And as a result of that, you have to resort to resection. All right, so any bone cell could actually give rise to a tumor mass. It could be a benign tumor mass, it could be malignant tumor mass. For example, the osteoblast. An osteoblast may give rise to an osteoma. Also, this is a benign bone tumor, the most common benign bone tumor. It may also give rise to, actually, it may give rise also, it is, I take that back, it's not the most common bone tumor, so take it back, because I know that you guys probably are recording here. Alright, so, like your class is very, punctual when it comes to that. So I need to be careful. It is not the most common, it is one of the most common, bone tumors. It's a benign bone tumor. At the same time, this same osteoblast may give rise actually to a malignant tumor. In this case, it is the most common malignant bone tumor. The most common tumor that is arising from the bone. That's the osteosarcoma. Okay? Now, if there is a cartilage, cartilage is part of this. There are cells that may, give rise to a cartilage, what you call cartilage producing, tumors or cartilage forming tumors, including the osteochondroma, which is the most common bone tumor, and also the chondroma, and the same actually, cartilaginous cell, if you will, the same chondroblast, may give rise to a malignant tumor, in this case, chondrosarcoma. And in the past, we used to have actually tumors that were known to, that were not known to where they come from. For example, Ewing sarcoma. We know now that Ewing sarcoma cell is most likely, have an origin like peanuts, the primitive neuroectodermal tumors, a very, undifferentiated cell. The giant cell tumor, to this day, you will see that, rabbins go back and forth when it comes to the origin of the giant cell tumor of the bone. At one point in time, they call the tumor cells osteoclasts. This is where the name osteoclastoma came from. But they, then as a result of accumulating evidence, they changed their mind actually 10 years later, and they recalled it actually, giant cell tumor of the bone. The reason for this is that the tumor, the actual neoplastic cell is a monocyte that, looks like actually the original cell of the osteoclast. It comes from the bone marrow, okay? And that's why actually there's a confusion about it. You will see that Robbins does that a lot, back and forth. It could be coming, not from a bone, cell or a bone-related cell, but rather from a cell that is related to the bone marrow, what they call a hematopoietic cell. In this case, that's going to give rise to the most common overall, malignant bone tumor, and in this case, it's a tumor arising in the bone as a result, or as opposed to arising from the bone. You guys know the difference, right?
Yes.
All right, good. So the multiple myeloma is going to be that tumor. Fibrogenic tumors, arising from fibroblasts. It could be in the form of a benign tumor, such as a fibrous cortical defect, or actually malignant tumor, as sinister as fibrosarcoma. Histiocytic tumors, arising from histiocytes. Notochordal tumors giving rise to what is known as chordomas, courtesy of the phylocyphorous cells. All right, vascular tumors, again, you have, a benign, vascular tumor versus an angiosarcoma. Lipogenically derived tumors, such as what you see in a lipoma or a liposarcoma. And then, when it comes to soft tissue, there's a long list of neurogenically derived tumors. All right, so let's start with the benign tumors, the bone-forming benign tumors. Starting with the osteoma. Where do you see it? This is an important, actually, clue, when you are dealing with a tumor like this. Usually you see it in the bones of the skull. And that actually may result in its clinical manifestation. If it compresses the nearby, brain tissue, for example, that may result in a clinical manifestation. If it arose in the facial bones and it was blocking, one of the sinuses, that sinus is going to become infected, and that will result in clinical manifestation. If it's arising in the facial bones and it resulted in deformities, that's going to result also in clinical manifestation. The age of the patient is around 40 to 50 years of age. Now, what is the cell of origin? It is an osteoblast, When it is single, usually that means, there is a sporadic mutation, a simple mutation. In this case, it will be completely benign. When it is multiple, that's going to give rise to what is known as a Gardner, syndrome. Here's an example of actually an osteoma arising in the floor of the mouse. You can see that here, resulting from, from a recurrent actually occurrence of a lesion that was resected. Is still attached to the lingual part of the mandible with a small pedicle of bone. Okay, so you can see it's not really floating freely. It's still attached somewhere. You don't see the pedicle here, but you have to trust my word for it. So it's attached to the lingual part of the mandible bone with a small pedicle of bone tissue, and you see that it has these two sides. The radio opaque and radio lucent. If you take a section of this, you will see that it is made up of a benign osteoblast, but laying down bone. All right, now the other counterpart is going to be the most common malignant bone tumor. In this case, is going to be the osteosarcoma. All right, and you can see actually that it does also lay down new bone. That becomes eventually mineralized. Part of it is still mineralizing in this picture. All right, so it is, I did not change the word cancer. This was the second probably lecture that I ever gave, as a faculty. So it does have what you call sentimental meaning to me. I did not change the word cancer, even though it's not a cancer, right? It's a sarcoma, and you guys know the difference between a sarcoma and a carcinoma, correct? we have talked about this in the POD, okay? So this is a tumor of the mesenchymal tissue rather than the epithelial tissue, as you see in carcinoma. So the malignant cells actually here make the osteoid that becomes eventually mineralized, and that will give new bone. Now still, the bone that is forming too fast, does not have enough time actually for the dual action of the osteoblast and the osteoclast. And as a result of that, it's still weak and will result in pathological fracture. It is the second most common, malignant tumor arising in the bone. Why? Because multiple myeloma is going to be number one. And in terms of actually occurrence, it has a bimodal, age of distribution. The first one, 10 to 20 years, which is then what we call the primary actually osteosarcoma, usually arising without a preceding bone disease. And the second one is going to be in the older population that is going to be following a bone disease such as Paget disease or bone infarct or other radiation, for example. Now, one thing actually you will see that with this one here is the distribution of the primary one is going to be different. So, for example, the skull lesions, the skull bones are going to be more with the older variant, the secondary variant of the disease. So you'll see actually here that the most common site, and you can take that as a rule pretty much everywhere you go in bone tumor, the most common site is going to be the area around the bone, around the knee, sorry. The lower end of the femur and the upper end of the tibia, the area around the knee is the most common, 60%. That will be followed by the hip bone, and then the head of the humerus, and then 8% in the skull. Like I told you, the skull is going to be mostly with the secondary, variant of the disease. Here's an example of this. This is a tumor that you can see. You can say right off the bat, that it is a young person tumor. Why? Because the physis is still there. You can see that, right?
Yes.
And you can see the tumor. Sorry.
Yes.
Are you guys okay?
Yes.
All right, and you can see that the tumor is breaching, part of this physis. Not only this, the tumor mass is so large, it is going through this periosteum, lifting the periosteum and creating this, triangular shaped, lesion. Okay. Now you have to agree with me that it does look like a triangle, does it? Okay, good. So you're a true pathologist actually in this case. You answer to the man holding the bag of money. In this case, the bag of questions, right? This is an inside joke between you and me. All right, so you can see that, and that's on X-ray. So these are newly laid out bone, right? Newly laid out osteoid that will become mineralized. as a result of this, innovation, you do have a triangle. I mean, let's face it, you do have actually a triangle. Here are the two sides of this triangle, if you will. And, that's what they're gonna be called Coleman triangle, for radiologists, okay?
But doctor, what is the reddish part?
The reddish part, what is that?
Right above.
Here, this is a muscle. So it is in the muscle now. You can tell, the aggressive and the invasive nature of this lesion because first it has gone through the periosteum, right, destroying it, and also it's now actually in the soft tissue, okay? Now then also the size of the tumor itself should give it right. Now not only this, what are these lesions? Let's apply everything that you guys have learned in POD. You have sites that look very, dark, right? And others that are, bloody. So blood, the blood is resulting from two reasons. One of them is that this is a highly vascularized lesion, right? A tumor mass, when it grows so fast, it needs a lot of blood to do that. So this is one. Two, you have neoangiogenesis, correct? And those new blood vessels, walls are very leaky. So as a result of that, you start to see blood everywhere. Now, what are these, black?
Hemorrhages?
Usually this is necrosis actually. So usually necrotic areas, you cannot do it, you cannot touch it here. Necrotic areas, a lot of tissue will appear like a depression in the surface of the tissue. Why? Because the tissue has been lost. So you are actually, after you cut the tissue evenly, you try to touch it, to palpate it, and you will see that there is a depression in the surface of the tissue. This is resulting from necrosis, but you may also see it in terms of color. There's a change of color here that's also necrotic. Why necrotic? Because the growth potential of those tumor cells outstrip the ability of the tumor to produce new blood vessels. So as a result of that, there will be sites in that tumor mass that will experience ischemia and will die as a result. All right, you have a question?
Yeah, this tumor is again it started from the inside and pushing outward, or
Actually, this tumor started from this region right here, which is the metadiaphyseal region, from it right here. So it may start. So the question: did it start in the periosteum or did it start in the medullary? It can start really either way. That was a question that I was always trying to answer for myself first, and I could not really find any kind of what you call more common one area than the other. At least from what I read when I prepared the lecture. So, but it did arose. This is a tumor that is known to, arise very commonly in the metadiaphyseal region, right? So this is the diaphysis right here. This is the metaphysis right here. And you know why they call them diaphysis and metaphysis, right? Because this is a relation to the epiphysis, right? And then the epiphysis, which is on top of it. Now this patient right here. So this is actually the young patient that we are looking at. Now this patient is right here, is an older patient right off the bat, right? And this patient have what you call multiple, the Paget disease that have multiple bone involvement, what do you call that? Polyostosis, right? Polyostosis Paget disease. I think polyostosis. So as a result of that, it is very hard really to follow up all those bones at the same time. And unfortunately, some of those patients go on to develop osteosarcoma in some of the bones. All right, so we did talk about this. Okay. All right, I think I cleaned up for you, some of the genetics. I don't think that you should, but some of it has to be here. This is an example of that because the association of Paget disease with actually the osteosarcoma is pretty important. In this case, it is associated with this mutation that is seen, in higher numbers of familial versus sporadic, but it is seen in both. Radiation. If you guys are, like me, fancy, clocks, fancy watches, fans. What is that, right? The Rolex and at one point in time, the dials, of those watches were made of radium, even to this day, actually. And radium is a radioactive, metal, okay, a radioactive substance. And those actually workers in those factories that were making those watches used to, you have to you have to clean the radial dial with a brush, and to make sure that the cleaning is efficient and well done, they used to wet the brush with their tongue, and then they will clean the radial dial, and then they put it back again in their mouth. Those guys went on to develop actually osteosarcoma. Bone infarct has been also shown to be associated in the long run with osteosarcoma of the bone. All right, the clinical features, you will see that this is, hold on.
قلنا الاوستيوساركوما 53.
Say it again, I'm sorry.
Didn't you say الاوستيوساركوما 53 بدي؟
Yes, we did talk about this, yes.
There's also SQS.
The what, I'm sorry?
There's the SQS.
Right, this is actually in patient with the Paget's. So this is specific for Paget's, okay? And because we wanted to see any kind of link actually between a genetic link, if you will, between Paget's disease and osteosarcoma, and it seems those patients, when you do genetic, what you call genome-wide association study, that will allow you to look at the whole genome, and we looked at the whole genome of patients of Paget's disease who went on to develop osteosarcoma, and it turned out that those patients have this STM1 mutation. Okay, so this is where this came from. All right, so in terms of features, clinical features, you will see that it may look like a true inflammation. So there is a mass, there is heat that is associated with this mass, and there is tenderness. And of course, a lot of times there is actually, it's the limb is no longer functioning. So all the cardinal signs of inflammation, and that may actually progress all the way to pathological fracture. Here's an example of this. You can see actually that the tumor mass in this case has breached the physis region, the growth plate region. Okay, and it is a tumor that is arising in a young person because it is in a long bone, as you can see here. The tumor mass is huge, actually resulting in elevation and breach of the periosteum on both sides. You see that, right? Right here and right here. Here it's a little bit more. This is going to be called actually eventually the sunburst appearance. It's going to be called the Codman appearance or the Codman triangle, whatever the radiologist would like to call it. It is actually new bone that has been laid down, lifting the periosteum. When it mineralizes, it will look like a sunburst. Right. Here's another one showing you, that it is a large tumor mass. Right off the bat, when you look at tumor like this cannot be actually benign. The size of the tumor itself, for a tumor to reach that size, it needs a very powerful genetic drive, and that is actually a malignant tumor. It's an osteosarcoma, again arising in the metadiaphyseal region, and going both ways, in the medullary canal and also through the periosteum and into soft tissue, as you can see here. Here's the Codman triangle that we have talked about, lifting the periosteum, as a result of the newly laid out, osteoid. And then when it becomes mineralized and calcified, it will give, this rise to this appearance, the sunburst appearance. All right, we'll talk about this, about the necrosis, hemorrhage. We'll talk about this as well. And here are actually the osteoid that is being laid down by all these. How do I know that these are actually osteoblasts? What is the feature that is going to tell you that what you are dealing with is an osteoblast? At least, when you try to differentiate it from the other bone cells. One nucleus, right? Mononuclear cell, absolutely, very good. And what else?
Cuboid too.
Cuboid, nice, very nice. Okay, even though it can take really any shape, right? You will see that there are many different shapes that those malignant osteoblasts may take. The other thing is that it is not osteocyte because it is not surrounded with osteoid from all sides, so it's still laying down bone. Here are actually the malignant osteoblasts. In this case, they are taking a spindle shape, okay, looking like a fibroblast. So a tumor cell may take really any shape, it twirls. And in this case, it is a spindly tumor. All right, so 90% of the time are, 90% of those osteosarcomas are actually counted as high-grade tumor, highly aggressive, and with a highly variable histological features. Now, those tumors are going to be amenable to adjuvant chemotherapy, neoadjuvant chemotherapy. Why is that the case? Because it's a rapidly dividing tumors, and in our arsenal, we have actually tumor that we have treatment for that. Now, on the other hand, 10% of the osteosarcoma could be counted as low-grade, tumors. For those, actually, chemotherapy will not really work, and in this case, you have to do a resection. It's what you call really a controversy, because the opposite should, at least in the past, it used to be the other way around. That the high-grade tumors were the tumors that you would try to catch as early as possible and try to take out by taking the lymph out. And now we're doing the opposite, right? So the resection is left for the low-grade tumor. How about that? This tells you that it did actually move forward. One of the places that I trained in the U.S. was actually the H.Lee Moffitt Cancer Center. It used to receive about 1/3 of the cases of bone tumors, in the U.S. That was in the 1990s. Okay. So in this case, like I said, cured by resection with clear margin. All right, and there is like any low-grade tumors, there is a chance that this may actually progress into a high-grade tumor. Now let me actually go back again, from your hematology block and ask you a question. There are actually those lesions, those low-grade lymphoma lesions, right? If you guys still recall from your distant memory, which is a month away. You have, for example, the follicular lymphomas, right? Which is a low-grade tumor, right? You have also the small cell lymphoma. Now, those also actually have a chance to develop into a high-grade lymphoma. What do you call that actually syndrome?
Richter transformation.
Sorry?
Richter transformation. Diffuse large B-cell lymphoma.
Right, so into a DLBCL, diffuse large B-cell lymphoma. So you will see that someone who actually was diagnosed with follicular cell lymphoma, as time was doing fine actually, and then all of a sudden you will see that the lymph nodes started to enlarge in one group of his follicular cell lymphoma that becomes dominant. This is actually how actually a high-grade lymphoma is, right? You know what the difference between high-grade lymphoma and low-grade lymphoma? What's the main difference between high-grade lymphomas and low-grade lymphoma? Who said that? Excellent. Site. What is the site? Low-grade lymphoma is spread usually all over the body, right? And a lot of them are actually what you call it symmetrical spread. So symmetric, inguinal, symmetric, axillary, and so on and so forth. Whereas a high-grade lymphoma is what? Where is it spread? Usually it is a single lesion, right? It's a single mass that eclipses. There may be actually other lesions anywhere else, but usually it eclipses actually all other lesions. What do you call that syndrome? That syndrome is called the Richter syndrome. Okay, have you guys heard it before? Have you? Okay, Richter syndrome. All right, I have to ask you this because I am actually I am the pre-clerkship director and I am the year 3 director, so I should know what you guys know, and you will see me probing you, as we go along, not just in him, but pretty much in everything else. All right, so now actually here's a little bit of molecular profiling. You need to know that. Unfortunately, I know as much as as you. I know that you don't like to memorize names of genes, and I received a couple of emails about this. MDM2 and the CDK4. Where did you guys read that before? POD. If you remember the POD, what's CDK4? Cyclin-dependent kinase 4. Absolutely. Those are, and also the MDM2. Both of them actually are related to the cell cycle. So when you have amplification of those, what do you expect the cell cycle to do in this case? It will go into a hyperdrive, right? Giving rise to more actually tumor cells in this case, or in actually if this is a low-grade tumor, what do you expect it to do? MDM2 and the CDK4. So if it's a high-grade tumor, it has to go into a hyperdrive, correct? If it's the opposite, low-grade tumor, what do you expect?
Differentiation.
What is it?
Differentiation.
Differentiation, one word. Apoptosis, excellent, excellent. Apoptosis, so in this case, you will see that those cells will not die, like all actually low-grade tumors. Example of that, follicular lymphoma, right? You know, where you see, you know, that there is, you know, BCL2 overexpression. All right, so not only, you know, unfortunately, it does not really cut it all the time, you know, that there is also 10% of a high-grade osteosarcoma that does have the MDM2 amplification as well. All right, you guys wanna, I can see that you are a little bit, and I wanted some a break, right?
Yes.
5-10 minutes break,
Yes.
and then we continue.